Every month, GBMC Healthcare brings you top experts to address health topics that matter to you. Here's to your health with host John Lazaru.
It has been more than 2 months since the first coronavirus case was identified in the U.S., and it's been over a month since the first 3 cases in the state of Maryland were announced. And according to a recent analysis from the Center for Disease Control and Prevention, everyone is at risk for COVID-19. Every day, doctors learn more about COVID-19. The amount of information that's been gained about the new coronavirus is overwhelming. And some of the things we thought we knew about the virus, well, they've changed over time. Joining us again to talk about what has changed over the last 2.5 months and what we still need to know about the coronavirus is Dr. Theodore Bailey, Chair of the Division of Infectious Diseases at GBMC. So, Dr. Bailey, I know you and your team have been doing a lot of work, especially over the last month with regards to COVID-19 and the coronavirus, but let me ask you, how are you guys doing?
We're doing well. I think one of the things that sort of put us in a good position was that this was something that began elsewhere. We had what I think of as a lot of lead time and advance notice to start to bone up on it, keep up on the new research that's coming out, and get ourselves ready for it before we saw our first case.
So I'm glad that you mentioned that because we're going to dive right on in. So, you and I spoke about a month ago, right, when all this was happening. And the last time we spoke, it was before even the first 3 cases in Maryland were announced. So briefly, if you can just let us know, what do we know now about the coronavirus compared to what we knew back when we spoke about a month ago?
I think we have an increasing awareness of the extent of asymptomatic or infections with no symptoms. And that was something that even in that time we knew we didn't know enough about. There's still room to know more. But in the early phases when testing was more limited, because testing was still in the process of being invented and rolled out, the testing had to be prioritized towards sick patients. And therefore it gave us a skewed perspective of corona as almost always having symptoms or most often having symptoms, but it really, therefore, was not being rolled out and just tested on anybody. So we had less of a sense of people with 0 symptoms who might also have it and therefore be able to transmit it.
Now, we're going to talk about asymptomatic transmission in a second, but I wanted to go back to something you mentioned about research. What do you think about the quality of most of the research that's been coming out almost live as this pandemic unfolds?
It's as good as it can be under those time pressures. This is research that would and does not suffice to, support various treatment measures, but it is the basis for developing hypotheses, motivating larger, more controlled trials that can investigate the claims that are made by the initial small studies. You can think of these early studies as the equivalent of circumstantial evidence. And you can think of us, in a sense, as a global courtroom. We're really looking for strong evidence. But you have to begin with the small bits of circumstantial evidence, maybe as an investigator, as a police investigator, and then you build your way to build your case. And that's what we're all collectively aiming towards, is to build a case for what's the best possible approach to managing this. And I should qualify my use of the word approach, because it actually probably is the best possible approach because it is a diverse epidemic. There are diverse clinical scenarios and diverse situations that patients find themselves in. So there may not be some silver bullet best thing to do for everybody. It may be that we need to be able to understand different trajectories of the infection and know where we are and then know how to manage that particular scenario.
So you bring up a good point, because my next question is, we talked about what we know, and what do we still need to know about asymptomatic transmission and the coronavirus?
Well, I think one of the things to know is how widespread it is. What I would say already is there's a lot of power in knowing and feeling more comfortable that we really don't know, that there's the potential for there to be quite a bit of asymptomatic carriage. This goes back to our last meeting, because we invoked Socrates. So wisdom is knowing that you don't know something. If we can't have confidence, and we shouldn't at this point, that there isn't much asymptomatic infection out there, then we should really be taking seriously the claims to withdraw, to stay in place, to social distance. Those are things that we should take seriously, even if we're not around people who are hacking and coughing around us.
And we'll talk a little bit about social distancing later on in our podcast. One of the things we we talked about is some of the things we knew and some of the things now we're learning as this thing evolves. One of the things that we talked about is how the coronavirus enters the human body. So the way that the coronavirus enters a human body, could that be significant to the severity of the disease?
Well, one possibility would be, what we call the amount of exposure. And I would say that one way to think about this, though, is each virus that you might come in contact with, each actual microscopic virus, you can think of it as its own roulette wheel. Does it land in a way that allows it to get into a cell and replicate itself and move on from there? So if you are spinning only a single roulette wheel, the odds of drawing a house number is much lower. If you're inundated with a very large quantity of virus, and each of these viral particles at least has a chance to make contact at a site that might lead to infection, then you have to win all of those spins. And even if every one of them individually statistically is in your favor, just the sheer number of them may lead to you acquiring, a progressing infection.
So exposure is basically what it comes down to, correct?
My point, though, is that exposure isn't all or nothing, right? There's degrees of exposure. Were you exposed to as low as a single viral particle, or were you exposed to larger amounts of it? And the odds of acquiring a progressing infection will be higher as you're exposed to more of the virus. And that's why duration and proximity to another person makes a difference, because that's going to ratchet up the amount of exposure you have.
Joining us on the To Your Health podcast is Dr. Theodore Bailey, Chief of the Division of Infectious Diseases at GBMC. Dr. Bailey, I wanted to ask you about aerosol transmission and droplets. Do droplets linger in the air?
Well, what we define as droplets do not linger in the air. And this, again, turns on a difference in size. So the things that are called droplets are, by definition, slightly larger. They're still microscopic. You can't see them. We're talking down into the microns or micrometer size, but they're large enough that they behave just like a tennis ball, something that gravity will take a hold of. It will come out of the respiratory tract, but then it will immediately begin to arc downward. However, the so-called aerosols are much smaller respiratory particles. Because they're small enough, the air molecules themselves can act as a bit of a support for them. They're able to waft in the air and travel out a further distance. It seems that the predominant mode of transmission is droplet, therefore limited in space. And that's the basis for the social distancing. We talk about 6 feet as a good cutoff there, because things will arc downward and sort of hit the ground before that. But there may be some small amount of aerosol, and that's a concern that leads to using a different kind of mask in close quarters or in certain procedures that generate an aerosol. So, for instance, in a hospital setting, when patients get intubated, which does happen in the severe cases, that's believed to generate an aerosol of the smaller and finer particles, and that's why in those particular situations, this other kind of mask called a respirator or an N95 is used there, even if it's not used in other kinds of settings.
So you mentioned masks, and I want to get to something that you discussed earlier. I like to run. I like running, and sometimes I am running either on the track or I'm going through certain trails, and I try to do my best, in keeping a 6 feet distance from the person, that's either coming the opposite direction or that might be sharing the track with me. However, if this person sneezes or let's say coughs in my direction, should I be concerned? Should I be wearing a mask, basically, since you mentioned masks, while I'm running?
Well, I would say not necessarily. And I think right now both the CDC and Surgeon General are calling for that to be revisited, because all these things should be revisited. But in the face of the fact that this is predominantly droplet, and the thing we talked about earlier is really key here, which is that the closeness, the proximity, and the duration, all of these increase the number of roulette wheels you spin to either get or not get infection. And so you're talking about a very brief and if perhaps distanced exposure. So that would be a relatively low-risk exposure. And in those kinds of situations, if you can maintain those things, it's not clear yet whether a mask would make a difference if you're maintaining recommended social distance. And so, that's why that's such a strong recommendation right now. As they review the evidence, they may also say use the masks. But here's the thing: we may ultimately be seeing recommendations from the CDC and the Surgeon General for adding masks into the general population. But I would take that as a reflection perhaps on the fact that people haven't been as good as they should have been about social distancing. It may reflect a kind of pragmatic response to, well, Americans just aren't good at social distancing. We've been given notifications from all of our politicians and leaders to do it, and we just haven't done it right. And this is the means for handling us because we're just not good at doing what we should do.
I agree with you, Doctor. I've seen stories where people continue to have parties at their house where they're gathering 10 or more people, and they're just not listening, unfortunately, to the science and to the recommendations that, hey, in order for us to beat this, we have to, keep social distancing at the forefront, in the front of our minds. So let's talk about some good news, though, okay? There's been a lot of talk about people that have been dying from the coronavirus or COVID-19. However, there have been some people that have also survived COVID-19. Question for you is there any science that's looking at patients that have recovered from COVID-19 to see if they've had any lasting damage such as chronic kidney disease or heart disease? And the second part to that question is, for those that have recovered from COVID-19, when is it safe for them to resume contact with the uninfected public, like going to the grocery store?
So we believe, I'll take the last question first because we do have some guidance on that. And again, all this guidance may be amended as more and more information pours in. But the CDC does have guidance about coming off isolation if you're someone who was tested positive. And, the recommendation would be that you get to a point where your fevers have broken without the addition of Tylenol or any other, fever breaker, that if you had respiratory symptoms, that those have improved, and that you then also have 2 negative tests 24 hours apart for the COVID. That even though you tested positive earlier, now you can be tested and tested twice and not detect it. And that's one way. Another way would be without the testing, because testing isn't always easy to access still, would be to get further out from your fevers, several days out from your fevers, and with improvement in your respiratory symptoms. And a certain duration out from the onset of symptoms. The details matter, and they get updated periodically, so I would always just refer somebody to the CDC website for discontinuing COVID-19 isolation.
Joining us on the To Your Health podcast is Dr. Theodore Bailey, Chief of the Division of Infectious Diseases at GBMC. Dr. Bailey, here's a follow-up question. If you get COVID-19 and recover, can you get it again?
Well, we know that there are other viral infections that one can get again. I would say it has to be entertained as a possibility. Why might one be able to get an RNA virus respiratory illness again? Well, why do we get flu again, right? We get it one year and we get it again the next year. Some of us don't get it, but the reason for that is mutation. The influenza virus is an RNA virus, and so is the SARS-CoV-2 virus, and the RNA viruses are notorious for increased mutations. Their replication doesn't have the same quality of proofreading. So when they make copies of themselves, those copies can incorporate changes. And those changes can accumulate over time, or they can be changes at a critical part of the virus that was where your immune system was targeting it. And so they may begin to escape detection by your immune system. So another virus example would be hepatitis. Somebody might get hepatitis C, get treated for it, and potentially get it again. Nowadays that we can cure it. So I would really caution against over-reliance on a sense that once you have an infection, you don't get it again because the immune system kicks in. We have a number of these are non-viral infections where we see antibodies produced by somebody who gets it, but those antibodies are not considered fully protective.
So let me ask you this. Most of the data that has come back, Dr. Bailey, has shown that the majority of those who come down with COVID-19, their symptoms tend to be mild. However, for those that become more serious, it seems it turns into pneumonia. If you had the pneumonia vaccine, do you think that might protect you from becoming seriously ill, or is it helpful at all when it comes to COVID-19?
No, it is not helpful when it comes to COVID-19. So technically what we have is a vaccine against a bacteria called strep pneumoniae, and it shouldn't really be described as a pneumonia vaccine. And in fact, the bacteria strep pneumoniae can cause a range of other infections, including meningitis. It can be quite destructive. It's a bacteria. The vaccine is highly effective against it, but that's not what COVID-19 is. This is a viral infection, so there would be no expected protective benefit from the, quote, pneumonia vaccine for COVID-19. Pneumonia, the technical term just means an infection of the lungs themselves. by any cause. It can be a viral pneumonia, could be a bacterial pneumonia, could even be a fungal pneumonia. And so as long as it's an infection of the lung, it's called a pneumonia. And therefore, your vaccines are only good against that particular cause of it.
Dr. Bailey, there's that old term that desperate times calls for desperate measures, and you see the figures, you know this better than anyone, the figures that keep coming in as far as exposure and those being diagnosed with COVID-19 and the coronavirus. And what I mean by drastic measures is, there's a lot going on out there about taking certain medication or drugs that are possible cures for other ailments and combining them and using them as a possible cure for COVID-19. As a physician and a scientist, do you think this and the combination of drugs that have been approved for other illnesses is a good idea in trying to find some way to curb the coronavirus COVID-19?
That's a challenging question. It's one of the ones where I feel like it's almost too early to responsibly weigh in on that. I apologize.
No, it's okay. If it's too early, it's too early. And if the science is not there, we'd rather be on the side of caution and just saying, hey, there's not enough science out there to address this at this time. Let me ask you this question. Could someone who has the COVID-19 infection and the flu, would that impact their symptoms, and would it be worse, and could they be sicker for an extended period of time?
Well, they can be. There are two different viruses. There's no reason why you couldn't get them both. And I think one of the dangers that may arise in the face of COVID-19 is a sense of attributing all of everyone's symptoms to COVID-19. And if COVID-19 is as contagious as it is, it's certainly capable of hitting people who were dealing with some other medical problem at the moment they were exposed to it. And, the fact that you had some other problem going on is not a free pass from acquiring a COVID-19 infection. And then acquiring the COVID-19 infection doesn't suddenly cure or fix whatever the other health problem was. But what happens is, when someone comes in and the testing may show COVID-19, and because COVID-19 is something we're still coming to learn about, it's sometimes too easy to attribute all of the symptoms to COVID-19 because we don't know any better in some cases. You're like, well, maybe it can do this. We don't know. So what it sometimes leads to is overlooking, or the potential for overlooking, something else that's also going on at the same time, and that's going to be detrimental. Flu would be one of those things. The tragedy there is, of course, that flu has a treatment, right? So you might get somebody who happens to have flu and COVID, and because the COVID is tested, they're shunted away from being worked up for flu, and therefore they don't get the Tamiflu, the oseltamivir that's treating for flu. And that could lead to a worse outcome than would otherwise have been the case had the flu been treated. So, and that's not going to be unique to flu. It'll be true for other kinds of conditions like a bacterial pneumonia that might be there also.
You talked about social distancing earlier in our podcast, and I have to be honest with you, I think that's one of the frustrating things that we talked about is that two things that I find frustrating, and please let me know if you share the same frustration, is people that say, I feel fine, I don't have it, therefore there's no way I can transmit it to anybody else. I mean, that's the first one. And then social distancing, which we talked about. I mean, in your opinion as a scientist, do you think our state, the state of Maryland, and other states across the country are doing the right thing by still imposing social distancing? And if so, how long do you think it will be before we see the benefits, or whether this has been effective in trying to contain the spread of COVID-19?
I will represent myself as a physician who takes science seriously, but who's not currently carrying out scientific experiments. I would see this as something that we should not expect to see benefits or the true impact of for approximately a 4-week period of time from onset of social distancing. And even then, the results may be underwhelming just depending on how compliant we have been. It's very easy to go and say this state has this or that regulation or law in place. This state has shut down its restaurants. This state has shut down its schools. This state is saying shelter in place. We can measure that perfectly, just by reviewing their current laws and regulations. What we can't measure as precisely, and which is in fact sometimes quite diverse within a single state, is how people are complying with that. So, we might be tempted to say, well, oh my gosh, we're 4 weeks into social distancing. We had these very stringent regulations put up, and we're seeing an underwhelming impact on it. But we have to realize that it's only as good as our compliance with it, because then it's in word only and not in deed. It has to actually be done for it to have the projected and expected benefit. But we wouldn't be able to see that for several weeks out, as I said, for approximately 4 weeks. And that's based on the incubation time of the virus. For the first 2 weeks into robust social distancing, you would have a number of people who were already infected before social distancing who have yet to materialize the symptoms of it. And then they in turn may pass it, with their household contacts. And again, it's not that even with social distancing, our people, they have to go out to get food, they have to do these things. So there would be some secondary transmission. And then in the second 2 weeks, you would see the people who might have picked it up from them still being socially distanced. And therefore, hopefully at that point, they're not being exposed to any new people, if they're really taking things seriously. And then we would begin to see some impact of it, flattening out the curve and maybe even reducing the rate of new cases.
You mentioned about people, and there's still a lot of people out there that are comparing COVID-19 and the coronavirus to the influenza virus. Do you think that's still a fair comparison or a bad comparison? As an infectious disease specialist, what's your thought on this?
So I think comparisons are a useful thing. If you go to a fishing club, you're going to see the fish that were caught in previous seasons, and you can compare your fish to theirs, and you get a sense of where you fall. So the comparison is helpful. So the things that we know in relationship to influenza is that the SARS-CoV-2 is quite a bit more deadly on a case-by-case basis. Now, we're decreasing how much more deadly we believe it is as we accumulate and find more asymptomatic cases, and therefore we realize there's more of it out there. But even with those allowances, we're recognizing that it's probably somewhere in the vicinity of 6 to 10 times more dangerous. And there's nothing about the virus that would make it less widespread than flu. Then you're really talking about a dramatic number of deaths, well beyond what we see with flu. And I would even say this, the flu deaths that we saw in 1918, which is often cited as the really spectacular pandemic of the last 100-plus years, that was done at a time where we didn't have modern ICUs. We didn't have the same ability to intubate people to maintain their respiratory support. We didn't have antibiotics to handle bacterial infections that might develop along the way. That was done at a relatively primitive age of medicine. The death rate that we're seeing right now with COVID-19 is in the context of 2020 medicine, with modern ventilators, with 60 years of experience with antibiotics, with all of the things that we're so proud of developing in the 20th century, and yet despite that, the death rate we're seeing is higher than what we saw in 1918 with the flu, which would suggest that if you put COVID-19 back into 1918, it would have been unbelievably worse than the greatest influenza epidemic ever.
It would have taken a lot more lives back then, for sure, given the fact that the medicine, as you said, back then is not what it is today. What we started the program about talking about what we thought and what we've learned over the last month. I just want to, go over a couple things with you and tell me your thoughts on what we thought back then and what we've learned along the way. Those most likely to die from complications of the COVID-19 virus are older and or have chronic medical conditions. What we thought then, what we've learned along the way.
That remains true, but it cannot be allowed to conceal the fact that we are still seeing very severe cases among the supposedly low-risk group. What does risk mean? Risk is not all or nothing, which is, I think sometimes, unfortunately, there's an element of medical illiteracy where I say, okay, that's the group that's actually having deaths in it. The low-risk group, we just get it and we're sick. But the thing is, it just means that there's less frequent, less common severe illness. It doesn't mean that there's none. And when it's severe, it's severe. Right. And so we do see deaths among younger patients.
The next question, you had to have symptoms of the virus to be able to transmit the virus. I know we touched upon that before. If you could just briefly reiterate your response on that one.
That really should never have been thought seriously. It should have been always felt that we don't know. That was true, or at least largely true for Ebola. But based on past experiences with similar viruses, it really should never have been believed to be true. And I would say you can feel confident there is transmission from asymptomatic cases.
All right, before I let you go, I got to ask these three questions. Are you ready? Will the spread of COVID-19 be affected by changing seasons?
Not reliably, no. We have SARS-1 that definitely petered out in the summer, but it had far, far less momentum behind it. And we have another virus called MERS, which is another coronavirus with a high fatality rate, but not very many cases. But we've seen that from year to year continue to have sporadic cases. And so I don't think there's any reason to have confidence that that will be the case.
Dr. Bailey, you've provided us with a lot of great information today. Where can I or our listeners get up-to-date data about the coronavirus in the U.S. and even the state of Maryland?
Both the state itself, its public health department, maintains a website for COVID, and then the CDC, you can't even call it a web page. It maintains a variety of web pages related to corona and maintains some updated information. Johns Hopkins University is maintaining a tracker of cases, so one would be able to see the cases that are present in the U.S., present globally, present in locally as well.
Any last thoughts you have before we leave today, Dr. Bailey?
Tony Fauci, who's been in the forefront of the federal response on the medical and science side of it, said that timelines are really going to be dictated by the virus. We can't dictate the time frame to it. So we have to take this a week at a time and be looking at the information, looking at how it responds. We should recognize that if we were to make serious headway in reducing the rate of the infections and prematurely lift measures of social distancing, there's nothing about the virus that would keep it from coming right back up again. And the right metaphor would be to see this akin to a wildfire. The fire department gets it most of the way under control and then decides for whatever reason to just go back home while several acres are still burning, down from maybe many thousands. Those remaining acres may set off a fresh wildfire. So the goal of a fire department would always be to get it to a point where it's put out. And I think that we should approach this infection with the same mindset.
Dr. Theodore Bailey, Chief of the Division of Infectious Diseases at GBMC. That's all the time we have for now. If you have any additional questions, please feel free to visit gbmc.org/toyourhealth. I want to thank all of you who listened to this edition of the To Your Health podcast. Most important, though, I hope that you are better informed about the coronavirus and COVID-19. Dr. Bailey, you're awesome. You're fantastic. I want to thank you again for joining us and again for all the great information that you provided to our listeners. And listeners, please be well, stay healthy, look after each other, and until the next time, cheers and to your health.
You have been listening to Your Health with John Lazarou. Each month, To Your Health brings you intimate conversations with a leading GBMC expert on the healthcare topics that matter to you. We're dedicated to keeping you well at birth and through every stage of your life. Learn more at gbmc.org and visit gbmc.org/toyourhealth to contact the show and get episode updates. This has been To Your Health.